Well, it looks like we've got a good attendance, and I would like to welcome everyone who is logging in. We'll probably have again throughout the meeting have people logging in and out as they are able to. But we'll go ahead and get started because we do have a lot to discuss. We do have a panel who is going to help us navigate some of the kind of technical nuances of what's happening around PDAB. So we're going to take a little bit of a dive into some things since our last PDAB workshop. As many of you know, a number of us have been involved, including many of you who are on this call, on PDAB efforts in Virginia, Maryland, Colorado. A number of the names that I see already logging in have been involved in Vermont and Illinois. And so we appreciate everyone's attendance and really would like to take some time with this panel today. You'll notice that we have broken it up into two sections on purpose so that we can talk through first some of the technical issues with PDAB, but then talk about some of the updates, where we're at, what are some of the critical path things that we need right away, as in very current with today. We're going to need some assistance weighing in on a few states. So our structure of our workshop for February is different than it was in January. And I hope that this helps us get through some of the issues. We would love, again, your questions, comments, feedback. If you can feed those to us either in the comments, and Kelsey or I will call them out and work with the panelists to answer those. That would be terrific. We really want to encourage you to be involved with us throughout the next hour. So we're going to do a very brief kind of overview again. There are slides that many of you who were on last month will have seen. And then we're going to shift gears into the intersection between PDABs and prescription drug utilization. There is a world of difference between those two sides of the coin. And so we want to talk a little bit about that this afternoon. And then, of course, our final section of this session will be talking about those updates. So with that, let's, again, just dive into just a top line overview of what a PDAB is. And then we can jump right into the next panel. Again, these are some slides that we used last month. They're just helpful in us getting our feet underneath us in terms of the landscape. As many of you know, Maryland was the first PDAB. It was established in 2019. During 2020, 2021, there was a lot of uncertainty about how to move forward. Again, we were in the height of COVID. The governor at the time was not supportive of PDAB, Governor Hogan. And so there was a lot of uncertainty with regard to implementation. But again, they're the longest running PDAB in the United States, even though they have a much narrower remit than some of the other states. We have seen states this year that we've been actually involved in, and I forgot to put Nebraska on here as well, in Virginia, Vermont, Illinois, Maryland, and also Nebraska. But we will be talking about some of those states specifically in the next portion of our program. But we've seen the board kind of expanding in terms of those who support PDABs actually now trying to expand the board and bring other states into this kind of PDAB structure. Many of the PDABs include what we call an upper payment limit authority. And so that's after they set up their PDAB and their personnel, their advisory board, or whatever they term it in their state to review, look at data, et cetera. Many of these are given the ability to actually set an upper payment limit. And that upper payment limit is where, as we'll talk about in a few minutes, we have some issues in terms of how that would interface with the prescription drug kind of ecosystem. But again, a lot of the members are appointed by political apparatus. Some of them do include patients. For example, Minnesota has asked some patients to participate on their PDAB. And some of them include government appointees that are often appointed by the governor or the legislature, et cetera. The scope of their research, et cetera, is often defined in statute in terms of where they start and how they look at things, with many of them having the foundational starting point being the WAC list price. And then, of course, a PDAC could be also linked to a PDAB, for example, in Colorado, where an advisory council reviews some of the key issues, makes recommendations to the PDAB, and then, of course, the PDAB would decide whether or not to implement. So again, these are just some generalities. Each PDAB's just a little bit different, depending on the state, how it's structured in that state, and the intention of the proponents of the bill.
And Mike,
Next
we have a
slide.
question. We have a question. Someone's asking if we can elaborate a bit more on the connections between the states.
The connections between the states. Well, a lot of, and this is based on some feedback that I'm going to give you from some of my work this session. The states are looking at each other, and depending on which side of the issue you are on, for example, some of the supporters of PDAB are looking at, for example, Colorado, looking at Minnesota, and they're saying, oh, PDABs are moving forward, these are successes, and that's filtering into other states. The PDABs, however, are not connected from kind of a regulatory or legislative structure, although there's a lot of discussion among supporters of building critical mass and looking at, for example, Colorado as being a success story or Minnesota being a success story. So that kind of interaction is going on. I hope that's helpful. If you need more clarification, please again ask a clarifying question, and we'll get back to it as we move into the other part of the panel. But this gives you a sense of some of the playing field that we've been experiencing this year. As you can see, we've already got PDABs implemented in 8 states. We've got a 9th state that's looking to pass PDAB, and that is Virginia. And then we've got PDAB legislation actually active in a number of other states, which are kind of the lighter colors. So the playing field is expanding, and the importance of patient involvement is growing. And again, we'll talk a little bit more about feedback, but as I've been involved in some of the advocacy efforts on the ground, there are a lot of people speaking on behalf of patients that are not patients. And so this is really an interesting dynamic, whether it's, the Commonwealth Fund, Arnold Ventures, or even AARP, which doesn't speak specifically from a patient perspective, but more of a consumer perspective. And when it comes to PDAB, that is kind of a nuanced differentiator, but it's a differentiator. And so we're seeing some of those interactions and that type of advocacy. And it's really important as the map expands that we understand that we're going to need patients to get more and more involved, because often the patient voices are pushed to the end of hearings, pushed to a point where they're cut off, or they run out of time. And so there's a lot of things that we need to incorporate into that. There's a question about 90% having no treatments. Yes, you can go to the Capitol and advocate. Because you're a rare disease patient, even if you don't have a therapy, and we'll get into that in the second session when we talk about specific states, yes, please go advocate. If they are too sick, we can do electronic communications, we can do testimonies. In some instances, we can even do video and share that video with legislators. If that's the case, please contact Kelsey and we will work with you to make sure that your testimony can be shared in the state. So thank you for that question, Jennifer. Next slide. So I wanted to get into an interesting discussion here, and I have a panel of very esteemed colleagues who are going to help us navigate some of this. And that is the intersection between PDAB and pharmaceuticals and the pharmaceutical ecosystem. And this is a really important section, and I know we're going to share a lot of information during this portion. And so please feel free to follow up with both RAP as well as the members of our panel, because we are really want to make sure that this information gets out to you and that you have an opportunity to both digest it and ask follow-up questions. So could we go to the next slide, Kelsey? I just wanted to share before we tee up this panel some of my observations, and I know I just shared a few of them a few minutes ago about what we're seeing during the legislative sessions on PDAB. And I think this is an important part of this discussion. We just talked about expanding the playing field, but we've also begun to see that there is a shift in some of the messaging around PDAB. From potentially saving patients money, as in directly saving patients money, to now there has been a shift in a number of the meetings and a number of my interactions with advocates on the other side to potentially saving the state and taxpayers money. So who the PDAB benefits and how it operates to benefit those audiences is, at least in my mind, and we'll discuss this as a panel, a little bit amorphous at this point. Supporters have begun to claim that PDAB upper payment limits will not affect access in the state. A couple of advocates actually said that to me a couple of weeks ago in Richmond, and a couple of the patrons of the bill there in Virginia also have said that to me. But they have said this without understanding many of the rare disease nuances to the ecosystem that they're just not aware of or don't understand. So again, that's something that I think is very interesting. We'll probably talk a little bit about in this panel. Again, both supporters of PDAB and their champions don't necessarily understand the implications of pricing decision in one state on the entirety of the ecosystem in which pharmaceuticals are sourced, paid for, shipped, transported, et cetera. And when questioned, they don't even, at least the advocates I've talked to this session have not been able to talk to me about specifics in terms of their understanding, but really kind of move back to generic statements on tackling drug costs without understanding the implications throughout the pharmaceutical ecosystem. In some states that still allow copay accumulator and maximizer programs, which directly take resources out of patients' pockets, there's not really a lot of understanding there. In some states that have passed copay accumulator bans, there's still not a lot of understanding there in terms of how the plans set the premium and the copay costs, how they structure that benefit, what level of premiums will affect certain drugs, and all of that. There's not really a tremendous understanding of how that works and how that would translate into patient savings. I do believe that there are opportunities, though, after a lot of these discussions, for continued efforts to lower patient out-of-pocket costs, exploring things like risk pooling, insurance market reform, and reinsurance for rare therapies. I think there are opportunities for us to lay the groundwork for other solutions that will immediately provide benefit for patients. We're actually doing some work on Medicare Part B. We're doing some work on potentially offering new insurance products that can be tailored more effectively towards specialty and rare disease medications. There's a number of things that could be looked at and explored that we may be able to gain traction on through some of these interactions around PDAB. So with that, I'll end that and let's move to the next slide real quick. Go ahead and move back to the title slide, Kelsey. If we could, what I'd like to do is just very quickly go around our panel, have them introduce themselves, and then we'll go ahead and begin our discussion on the intersection between PDABs and utilization of management programs and systems. So Jen, we'll kick it over to you first.
Hi, everybody. My name is Jen Laws. I'm President and CEO of Community Access National Network. We are a patient advocacy organization that has been in existence for the last 27 years, and Mike used to be on the board. That's part of the connection here. Our focus is on HIV, hepatitis C, and substance use disorder. And while this is not the same as rare disease states, we do have particular similarities in the issues that we have to tackle and how we have to get there. So there's a lot of crossover and agreement in terms of policy approaches, how best to serve communities, particularly underserved communities, as we see in certain rare disease situations, and marginalized communities across the country.
Kara?
Hi, everyone. I'm Karen Hinckley. I'm the Vice President of State Policy with the ALS Association. We're the largest nonprofit that's advocating and providing care services and funding research on behalf of folks living with ALS in the world. Our mission really is to discover a treatment and a cure for ALS, and to ensure that ALS is made livable in every state until we do find that cure. ALS is a progressive neurodegenerative disease. It affects the nerve cells in the brain and the spine. And as I said, there's no cure yet. I am based in Asheville, North Carolina, and happy to be on today. I'll also put a quick pin in the fact that we work stateside in the legislative arena as well as on the regulatory side. So I think that that's an important distinction to make. I'm in my second year as an appointed National Association of Insurance Consumers consumer rep. And so with that, we've worked quite a bit on that consumer lens, and I'm able to bring that rare disease lens to the table around a lot of what we're talking about today, especially around the utilization management tools and tactics. And I'll kick it over to you, Matt.
Thanks, Kara. Hi, everyone. Thanks, Mike and the RAP team for the invite and for your work in this space. Matt Prentice, I'm the Director of State Policy with the Immune Deficiency Foundation, or IDF. And at IDF, we advocate and work every day on behalf of individuals with primary immunodeficiencies, which are a group of over 400 rare disorders that impacts a person's immune system and their ability to live healthy lives. Thankfully, our community has access to immunoglobulin infusion treatments and therapies that allow them to really live a fulfilling life. And so our work really focuses on accelerating the time to diagnosis for our community, and then making sure that they have access to these important treatments and therapies. And I'm based in Virginia, and really just happy to be a part of the panel today.
Well, thank you, and welcome to all of you. I think that this is really an important discussion. And Jen, you kind of teed it up a little bit, and I'd really like to hear some of your thoughts, and then I'll move over to Kara and Matt as well. You know, we talked a little bit about PDAB and how PDAB looks at pharmaceutical price in isolation or within the confines of how it's defined by the statute that's enabling the PDAB. Jen, what are some of the challenges with that, and why is it important to have a more holistic approach?
There's a lot of challenges to that. I can say some of them. There's layers upon layers, especially when we look at it through the lens of patient experience. Now, a little bit of background is CAN has done a decent amount of work in the utilization management space, and part of that is taking the approach here is that utilization management's core principle is to limit cost exposure for payers, and really under this guise of cost containment. And what that ends up amounting to, especially for patients with chronic and rare diseases of any kind, is care containment, right? We see this from diagnostics to pharmaceutical products. It does not matter how it goes. It can even look like the specialist that you need to go see being in or out of network. So we're seeing, and it's a big deal, especially when we look at prior authorizations, step therapy issues, all of those things. And we're starting to see states push back against that as an issue, especially after the Office of Inspector General, of Inspector General or Government Accountability Office did a rather massive report about the abusive processes that we see it from payers in Medicare. It is a delay and deny process that is really kind of akin to what we expect to see from auto insurers, right? And it's gross. It's just gross when we're talking about day-to-day life. And PDABs kind of intersect with this, because when payers are given a financial incentive one way or another that is purely for them, then they're going to leverage what comes out of a PDAB in combination with utilization management practices to limit care for patients, right? The PDAB in that effort will contradict and undermine these patient protections that we're finally starting to see. So that is from the healthcare only perspective. Now, in HIV specifically, a lot of our single tablet regimens require taking food, for example, with your medications. And I know that's true across a number of health conditions. So they don't look at those barriers to care or barriers to access in terms of, are you in a food desert? What's the cost of transportation? How often do I have to see my provider in order to get through this? How much does it cost me in terms of time and physical effort in order to go to multiple pharmacies if I have to, because of their ability to navigate whatever payer barrier is right in front of them, right? So this idea of cost as an out-of-pocket only situation is not the only thing that patients see, but we often conflate those things as a cost of care being kind of piled all into one trash bin that should be set on fire. But that's how we operate as human beings in an ecosystem with multiple contributing factors to our access to care, which is part of why CAN focuses on that access piece, right? RAP and CAN happen to share access in our names. It is part of our mission. And helping to define those barriers and those other costs that patients might associate is really part of where we're at when we look at cost or affordability or access from the patient.
Thanks, Jen. Kara, I know, Jen kind of laid it out for HIV, which really would fall into the specialty care category, very complicated. And yet now as we look at rare, many of the areas that Jen talked about are exacerbated in rare. Could you talk a little bit about the ALS patient journey and how you see the interactions between kind of healthcare in general and the intersection with PDAB?
Yeah, absolutely. And Jen, I think you did such a good job of laying out really how the ripple effect of not only not having access, but also I think the fear of not having access and how that really impacts families and people living with rare diseases. So from an ALS lens, somebody's diagnosed with ALS every 90 minutes and someone passes away from ALS every 90 minutes. This is a disease that you're told you live 2 to 5 years upon diagnosis, and most people are around the age of 55 when they're diagnosed. It's very, very expensive in terms of treatment and care and all the things that come with that. Transportation, making your home an accessible dwelling. We've seen studies that indicate it can be as much as $250,000 a year cost-wise for someone living with ALS. So access and affordability issues, kind of piggybacking on what Jen was talking about, are incredibly important to people living with ALS and anyone within the rare disease community. I'll say we have 7 FDA approved therapies for the treatment of ALS. There are many, many more going through the drug development pipeway right now. And some really exciting things that we're hearing about are drugs that can potentially, for genetic forms of ALS, which are between 10 and 15% of cases, that could potentially stave off the onset of symptoms, like we saw with, multiple sclerosis in more recent years, which has been absolutely incredible. So we're seeing that on the horizon. So it's important now. Access is absolutely important now, where there are drugs available that can give you additional months of life. And when you're talking about a 2 to 5 year life expectancy, a matter of months is really, really important. And so when we dig down into prior auth and these auto denials, sort of the batch denials, I know ProPublica has done a fantastic job of really lifting this up. And I would, anyone who hasn't read their pieces on this, I would definitely recommend going to do that. But you're denying folks access to medications that really are a lifeline for them. And so I think everyone's already terrified about this. Everyone with ALS has dealt with denials. They've dealt with the appeals process. They've been really hurt and really harmed by the utilization management tactics. One thing comes to mind, and this is maybe the 5th or 6th email I've gotten about this issue just last week in South Carolina. It was one of their largest insurers requiring step therapy for a non-invasive vent. So they're denying a ventilator that a physician has said is needed, and they want someone to fail first on a CPAP machine. I don't know about you, but if somebody's telling me to fail first when it comes to breathing, it's just not okay. It's criminal at this point. It's predatory and it's not okay. I don't think I have anything more to add around the impact specific to folks living with ALS, other than highlighting, I think, the experience of our friends with cystic fibrosis in Colorado, and putting a pin in that stress piece, that how the fear, when everybody's already so impacted by delayed care and all the hoops and all the administrative burden, to then now fear that the one drug that is available to you for your specific type of this rare disease may not be for very long. It's really scary. And that stress is real.
Matt, we'll move it over to you. I know we had talked a little bit about some of these utilization management programs that now incorporate things like copay accumulators, specialty tiers, et cetera, and how those impact patient access and immediate out-of-pocket. And I know IDF's been very, very concerned about some of those issues. Would you like to jump in and share a little bit about your perspective there?
Sure. So, yeah, I mean, as a rare disease community, there are not a lot of treatments available. We don't have generic alternatives and biosimilars, and the process to get to a point where you're taking the medication that your doctor prescribes for you with PI is a long journey. I mean, besides diagnosis and everything else, as Kara and Jen touched on too, they're going through prior authorization and other barriers as well. And so they get to the point where, they're really clear to be able to start to access their medication. But then you have this whole other layer, which is all the threats to copay assistance, to financial assistance for patients. So imagine yourself as a patient getting up to that point, and you have this understanding that you're on this expensive specialty medication, you have a high deductible, high out-of-pocket maximum, but you're told that you can apply and receive patient assistance to cover that. You use that patient assistance at the pharmacy counter, and it just goes up into space, right? It just poofs, disappears, doesn't really apply to anything. It only delays the inevitable, which is still having to meet your entire out-of-pocket deductible. It causes a huge strain, stress, financial barrier. It is one of our leading, if not the biggest issue that faces our community. If I'm on the phone with our patient services folks trying to work through what someone is experiencing, it is them halfway through their plan year, completely surprised and shocked that they have been using assistance that has gone nowhere, and now they have this incredible financial burden they didn't plan for. And so it's a huge issue. And, you know, to kind of tie it in with PDABs, in a lot of our recent discussions where we're working on legislation, you know, we're leading the effort in Maryland and working with the All Co-Pays Count Coalition. I guess a silver lining, if there was one, of PDAB, and perhaps, Mike, this is your allusion to opportunities, is that through conversations around PDAB, we're able to talk more about out-of-pocket costs. Through these conversations where, you know, we hear about how industry or manufacturers have no skin in the game, we can talk about the thousands of dollars that our patients receive to help with copay assistance and to help with their out-of-pocket costs. And so it gets down to us. It's that, you know, there's just so much work to get to a point where you can take the therapy that you know will save your life or sustain life and provide you value. And PDAB is just this additional complexity that I can say, you know, the patient community, from my perspective, at least, I guess I'll speak from my opinion, wasn't asking for it, right? You know, and it's so complicated. To say that our healthcare ecosystem supply chain is complicated, you hear that all the time, right? Any article about PDAB, any article about utilization management, it almost sounds cliche, but it really isn't. You know, it's this very complex system, and to kind of pick at one piece without thinking about the downstream consequences is concerning. I think certainly for a rare disease community where we know we don't have alternatives, but I think for everyone.
I think, Matt, that's an interesting way that you framed it there. As we've been talking with legislators and things, even in states that passed copay accumulator reform, this year they don't quite remember what that did. And again, it's giving us opportunities to go back and remind them that there are things that we can do that can immediately have a patient benefit and put those resources back in patients' pockets. Whereas PDAB is kind of disconnected from that connective tissue that is what you pay, what your out-of-pockets are. So that's really interesting, because I do see that as an opportunity and a way for us to maybe craft some solutions that we can potentially move forward in the future, rather than isolate one component and assume that the downstream benefit is going to impact the patient in some form. As I had indicated when I was talking with some of the folks from AARP in Maryland, there was a revision of the benefit to, oh, now this will flow downstream and save Marylanders money. In general, it'll lower taxes, it will lower costs of programs, et cetera. And so it's one of those things where we can come back and refocus on the patient by engaging in these PDAB conversations.
I want to point out that none of the PDAB legislation that I've seen requires any pass back of assumed savings or achieved savings to the plan sponsors. So this idea that there's savings, I'm sure there's savings or profit value to PBMs in there, but there is zero requirement for that to come back to taxpayers alone, much less the patients directly. And I think that needs to be pointed out when we're engaging here. And this kind of speaks directly to the question we had earlier. You might not be able to make it to a capital, but we can work on writing letters, and I guarantee you legislators and their staff enjoy talking to constituents on the phone or through virtual meeting. There is far more awareness of the lack of access that people with disabilities tend to face when it comes to these things, thanks to how we dealt with COVID. So let's leverage that to your benefit and being heard.
I think something that's really important, and this brings up for me, I didn't know whether to hold it for our second part where we're diving more into the state specific legislation, but something that we've been advocating for is, if you're going to have PDAB policy moving in a state, ensuring that there is a patient impact study that's mandated with that. It's huge. It's shocking that it's not included. There's a number of things, and I'll go in. I have a list of like 5 bullets on things that if this policy is moving, these are the things that need to be included. But the fact that there is no requirement to look at where those dollars go, or to look at when you've locked someone out and you've established an upper payment limit, what does that then mean for these people that are being impacted? It's wild that is such a large oversight now that there's been so many bills.
Well, and there honestly needs to be additional study behind that, right? I'm not opposed to any state looking at studying an issue. Ohio did it very well. But we look at public programs. Like if there's public assistance programs that folks are getting into, Medicaid, for example, where they're getting access, we need to see how that program, as well as the patient, are impacted. When we start talking about that, it's a big, big deal. I don't think there's any harm in studying an issue and looking for the solutions and being part of that. But yes, absolutely, Kara, 100%. Like, honest to God behind it, an excellent idea.
Yeah, and Jen, I was just thinking as you and Kara were talking, in a rare disease model where we're looking at the kind of the growth and expansion of centers of excellence. And so, rare patients sometimes traveling out of state to get an infusion, to get medical care. And we're hearing now of, some of the facilities not wanting to go at risk, not wanting to, so basically you're going to have to brown bag your medication. These are real changes now that PDAB and the threat of PDAB not being able to make those facilities whole in terms of their purchasing. It could have that ripple effect to disrupt the care that we have today. And so, that's one of the areas I think, like you said, would warrant more study, understanding of how these things can affect patient journey, how they affect payment, how they affect the payment model that maybe a center of excellence hospital utilizes to purchase their medications, and how those out-of-state patients who come from a PDAB state where an upper payment limit is set, who would make that hospital whole? Some of those questions are kind of relevant. And so, that's a little bit of the work I think that needs to go into PDABs before we start pulling the trigger, especially in specialty care and rare disease therapies.
Well, I think there's room to also talk about how PDAB encourages utilization management and patient steering, kind of disrupts that patient-provider relationship that really gives us the best health outcomes, whether it's a public health concern like HIV or rare diseases.
Agreed. Well,
Mike,
with that,
we have a couple question and answers. I don't know if you can see them.
I do see.
They might be good for
we're
the
going to get
next
into
discussion.
a couple of them in the next session, and I see that you're handling one of them directly, so we should be good. Let's go to the next session, and that's the nice thing about this panel is that we're going to move into the next topic, and our panelists are going to be able to actually help direct us into specific calls of action. And Kara, you kind of teed that up by saying, look, we have 5 specific things, or here's what we need you to focus on. And that's what we're going to talk about now. If you could go to the next slide, Kelsey. We have a number of states that are currently active, and we'll get to Colorado in just a moment, but there are areas where we can call to action, and we've called them out in the slide deck. And we also have some contact information, links to where you can go to actually weigh in, the names of some of the delegates, et cetera. But there's ongoing activity now, and that call to action is really, really important that they hear from you, the patient, in terms of their process. The patient journey and the patient story, I don't think is really understood. And so, like I said, when I teed everything up, there are a lot of people who have good intentions and want to speak on behalf of patients, but they're speaking on behalf of patients without understanding some of the patient journey. So again, just some very specific things that are going on this week, and then I'll turn it over to the panelists and we can talk about them. First up is Virginia. We have a potential for the bill to be sent to the governor by the end of this week. It was passed last night in House committee and will be going to the House floor. And so all of this could wrap up by the end of this week and be sent to the governor for his deliberations and potentially a veto or to sign it. So we actually are going to need patients to weigh in as quickly as possible. Okay, so that's one. And we're going to get to Colorado because Colorado's kind of in the same position on two fronts. One is a technical amendment and the other one is on the regulatory side. And we'll talk about that in a moment. Second, Maryland, again, to reach out to the oversight committees, and we've included the names of those committee members. I've spoken with both of them. They are very interested in hearing patient experiences and understanding how this expansion of PDAB in Maryland could impact patients. They have, I would say, something very important about the action in Maryland is that the delegates who are trying to move forward with the expansion are doing so in a thoughtful manner. That doesn't necessarily mean that we will agree with them, but they are trying to be thoughtful. And I think that's an opportunity again for us. The next slide that I have just very quickly, could you go to that, Kelsey, is Colorado. And again, there's a lot going on there in Colorado. I mainly outlined the regulatory side where there is a PDAB decision coming up in Colorado that needs to have people weigh in on it. But there is also legislation moving that would carve out rare disease therapies from purview of the PDAB that we need patients to weigh in with as well. So again, patient voice is very, very critical to the process. And we would recommend, again, getting involved and encouraging you to get involved. Now, with that, I'd like to, if we could, turn it over to our panel to talk about that involvement. And if we want, we could go state specifically, or we can talk about in general and then drill down into some of the states, depending on how the panel would like to attack that.
Well, I think there's some value in talking a little bit about what's going on in Colorado because everybody keeps talking about Colorado. And what I will say is thank you, Kelsey, for your comments on this about who's pushing these bills. There are common through lines across each state, as well as the contractors each state that has established a PDAB are using. I have some massive concerns around that. It makes me feel a little bit like a conspiracy theorist. But I will not go into more detail than that at this point in time. As far as process with regard to the PDAB in Colorado, last Friday, the PDAB voted to declare Enbrel as, quote, unaffordable. They have a report review this Friday as mandated by their own policies. It has to happen within 7 days. And they'll finalize the report and then recommend or not recommend if the drug moves forward on determining an upper payment limit. So there's an engagement opportunity there because there is a possibility for a PDAB to determine a drug, quote, unaffordable, but not necessarily move forward with an upper payment limit establishing process. And that can come down to details in that report or among conversation that's happened at previous PDAB meetings or even then. There are major problems in terms of process. Patients have been complaining very consistently that the board waits until the end of the meeting to hear from patients and then cuts off testimony. Written comment is the most powerful tool there because of Sunshine Law and because the board members do read them. I will tell you they do read them because we got called out very specifically for our last letter submitted within 24 hours, and then wanting to go seek legal counsel. That was kind of fun. And I think that Embryal's at a real big risk here, in part because the data that was shown there and the data collection there showed 10 out of 19 patients with a copay around between $0 and $50 decided that created an access barrier to them. There's no determination that piece keeps being a moving target on what creates an access barrier or not, because it's given the same weight as if the copay is $1,000, or and there's no consideration on if a patient is accessing patient assistance programs. Like, this is a constant moving target to justify a move forward. And I think we need to recognize that as we talk about this. I think we need to recognize the dangers on this. And I think we need to recognize across states that PDABs will disproportionately target rare disease drugs, expensive chemotherapy drugs, things like HIV drugs, because they are expensive. They are expensive because they are life-saving. They are life-changing. They are life-improving. They make sure that we can engage with our society around us in as much a healthy fashion as possible. That is why they are expensive. They are expensive to make and invest in. It is hard, but we will always be targeted because of that.
Agreed. Matt?
Yeah, I mean, only thing I wanted to jump in to add too is just, let's say, you give the benefit of the doubt to the idea behind PDAB. And although you're skeptical and everything we've already said, the ecosystem is too complex, blah, 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 right? But you want to give them the benefit of the doubt and kind of see where they kind of end up. What Colorado is doing from a process perspective eliminates the faith in that, right? Like, as kind of a early, I've been a member of NASHP for years, right? As somebody who heard about this idea and thought about it for a couple years, and this relationship to utilities review and all this other stuff, right? If you kind of like go in slightly open-minded, which I have at times, they really have to prove it, and they have to show the data they're looking at and the way they're doing surveys and how they engage with stakeholders. And they're not doing that. And I worry that's going to happen even more with the existing PDABs, because I think after years of staffing and appropriated dollars and not really doing much, I think there's some pressure to do something now for these PDABs. And I worry that this idea of this rushed, qualitative approach to try to say something is unaffordable, it's just really, I think, concerning. And beyond the concept of PDAB, if the process is as flawed, then I think there's some real issues there.
Well, I want to point out, we had a question early on saying, hey, how do we get a hold of legislators if we can't make it to the Capitol? Attending these meetings is a massive burden. It is a massive burden. Patients struggle to make them because they are time consuming. In Colorado, those meetings are at least 4 hours long, very commonly. So, and now you're talking about both an advisory committee and a board. This is not meant to be a process that engages patients meaningfully. And I think that's the bad faith that really kind of exposes itself in terms of process.
Agreed. I want to point it out and just point people to the Q&A. Amanda Boone has put some links up for us for the virtual Capitol Day in Colorado. And then for submission of testimony, you can testify in person, online, and of course in Colorado, written testimony. Those links are in the Q&A, and Kelsey will send those links around after the meeting to all the attendees for you to disseminate through your Colorado networks. So again, as Jen and the panel we're talking about, it is a heavy lift to get patients there. And what's interesting to me is how it's set up that the very last people that testify are those who oppose the bill. And they're at the very end of the meeting, usually when there's a time constraint. And so their testimony is really just kind of brushed through the process. And so just be aware of that that it's not necessarily set up to encourage you to have a substantive testimony. So that's why also reaching out to offices, reaching out with written, here's how this impacts me, or a phone call, or any number of other ways are very, very important, both prior to the hearing and after the hearing, and after the vote's taken even. They need to hear from you in full. And sometimes these hearings don't provide that opportunity for them to hear you in full. Kara, anything else that you wanted to touch base on with, particularly with regard to Colorado?
I think just, some two points kind of came to mind talking about this. As a patient advocate, I think all of us know how often we're demanded to have data for everything, and why PDABs aren't being held to that same standard is frustrating. And then also talking about the advisory committee and the board, where's the patient requirement? Where is the rare disease advocate requirement in that language? If we're being thoughtful, then we need to be inclusive. So again, that's another one of those points that if you're going to have something like this, if you're really being intentional and thoughtful, you're going to mandate in the bill language that you have a rare disease or a patient advocate included.
I think that's a terrific point. And particularly, Kara, if you look at a state like Colorado that has an RDAC, there certainly was
It's already
opportunity.
built in.
Exactly. It's already there. Those experts there. They exist.
We should also, like, when we're talking about maybe suggesting amendments requiring that collaboration, because what happened in Colorado was that the Department of Insurance didn't consult anybody that's already associated with state activities. We had to, for HIV advocates, we had to bring in a former AIDS drug assistance program director in order to testify, essentially in a small group meeting, to the system's impact and the lack of care that would occur. It is hard to get that kind of expertise on your side when the department is refusing to collaborate. These things should be required.
Good point. Good point, Jen. Matt, I want to ask you a question because, again, we've seen this in Colorado. We've seen the impact of op-ed pieces, people submitting opinion pieces to local news coverage, et cetera. Could you talk a little bit about your effort in Virginia and why that's important that patients continue to reach out to local media?
Yeah, I really did. I do think it's important. I mean, we all in the policy space submit testimony, attend hearings, and do all that. But I think for PDAB, it's arguably maybe more important because there's a story to tell that I think benefits from what you can do in media, right? In an opinion piece and providing commentary. For example, everybody likes to say in Virginia that 80% of respondents to a survey want a prescription drug affordability board, right? Like they want it. But I don't think anybody gets to answer that kind of question understanding all of the things that we've talked about, really kind of understanding all the layers to this. They just say, my healthcare costs are expensive. That must be the price of the drug, right? It's just so like blunt tool, like sledgehammer approach, right? And so I think media has the ability to tell that story a bit better, especially for folks that don't, for everyone that doesn't read like all the testimonies supported for bills, it's just a way to connect. And for me as a Virginia resident, I found it hard to connect on this issue like I do on lots of other issues because, for lack of a better word, it's complicated, right? Like we definitely want to remove financial barriers and we definitely want to increase access and make sure that drugs are affordable. And so you really risk in, being so binary to either support or oppose something, you risk disenfranchising, I think, members of the legislature that really work with you on lots of stuff. And so that's a long way to say that I think the op-ed in the media provides a venue to tell a big story, right? To just kind of lay all that out so you don't get put in this person opposes it box, but just it's just a more holistic view. I mean, I think that's what we keep saying about all of this, is that it's really holistic and broad to kind of make improvements for patients, not really siloed. And so definitely encourage everyone. It's really accessible, and I think people are surprised when, if they write an opinion piece, it can be accepted and a lot of people read it.
Yes, it can be a little daunting to write the opinion piece,
Yeah.
but from my perspective, having been a former Hill staffer, those clippings come in, you're looking for your constituents, what they're thinking on key issues. And in Richmond, in Annapolis, in Denver, they are very, very aware of what's in their local papers. And so those opinion pieces, even if it's just a letter to the editor, often get shared at committee meetings. They're talked about with staff. And so it amplifies your voice. And I think, Matt, you're exactly right that it gives you an opportunity to break out of that maybe 2-minute time that you have to testify at the end of a very long hearing day. And then you get cut off early because the chair wants to go to another event or something. Those things are real and they happen. And an opinion piece gives you that opportunity to get out there and amplify your voice. Jen and Kara, I'd like to kick it over to both of you for some closing thoughts.
I'll go first because Jen's closing thoughts are going to be way better. So I want to leave everybody on that note. I think just again to the kind of thoughtful way to really address this, the issue of healthcare cost containment. States have been creative and looking at this issue for many, many years. I was with the National Conference of State Legislatures over a decade ago, and we had a big health cost containment effort between Dick Kelke and I ran that effort. And you hear a lot of things come up and they go away and they come up again. We know this in state policy. It's like a pendulum. Something's terrible for 10 years and then it comes back. This feels very different. It's untested. And it's very dangerous for those that we all serve. And I think, we work in public policy. It's our job to, spot those unintended consequences for folks who are well-meaning. But at the same time, when we highlighted this and we've said this is a problem and we've seen firsthand the havoc that this, had in Colorado, and then we're still doing it, it doesn't make a lot of sense. And, the fact that these bills are still being filed without a rare disease exemption when Colorado's, trying to do the fix, it's, I can't just say it's just because they don't know this or they're not considering this, right? And I think that's kind of the elephant in the room, like they know. And so we have to, I think, really bring the heart of what we all do. And that is bringing patients to the Capitol, bringing patient stories to the Capitol. One thing that we launched was a share story component on our website. So folks can go in and they can do an audio recording, they can write something, and they can also do a video recording. And that's been something that's been really, really helpful. And I mean, with YouTube channels, we can make it so it's more accessible for patients to be able to get their voices heard. But I think it's really going to media with this as well. The lawmakers, of course, they need to hear it. And we need to, every phone call, every testimony, every letter of support or opposition, as much as we can, get those tack marks made. But at the same time, I think this is really like a hearts and minds piece that the media appeal is, I think, as important as the legislative work right now. I'll throw it over to you, Jen.
Well, and ultimately our legislators are responsible, right? Like they're responsible and they're quite responsive to media attention, because when this goes sideways, and it will, and we know it will, right? That's not a headline they want to deal with. And I think pointing that out is really kind of important. And I know this is burdensome. I mean, and I have been on calls with each other, trying to support each other through this Colorado thing. I've been on calls with all kinds of advocates through Colorado. The same thing happening in Illinois and everywhere else. And I know it's taxing. I get it. I do. And I think we've got to be mindful about that as we make strategic investments and approaches to make sure that drumbeat is steady. Is to be mindful of patient capacity as we do this. And this is preventative. Intervening now is preventative, because the cost, the person cost, the human cost to spending time with your family, actually losing access to care, all of those things is enormous. We've got to make the work to stop that now. Now, that said, in Colorado, the advisory committee did advise, because we don't know how this goes, advise the board not to approach anything with an orphan drug designation. And they near exclusively did. And that's the thing. It's cute to have an advisory council, but if the board's not held accountable to that end, then that's a problem. And it's part of why we're seeing this kind of post PDAB legislation coming forward, is it's really just trying to cement the advice that was already given. And I think that's true. I think that's going to be applicable across all states. I think when you're dealing with public health concerns like HIV or hepatitis C, right? Like these are massive concerns. Have you guys seen the syphilis numbers that just came out? They're the highest since the 1950s. That's nuts. But that's what happens when we don't have access to care in infectious diseases. When we don't have access to care when it comes to rare disease states, we see families fall apart financially. We see people die. We see strain on systems as people have to end up spending countless hours in a hospital, countless days in a hospital. This argument on cost of system is nonsense. It's distraction. And I think calling it out really matters. So get your talking points down. Make sure that you're ready to, like, if you're going to go hard. Talk about that personal piece, because we can be wonky policy nerds all day long. I keep saying, I look like a conspiracy theorist anytime I try to explain supply chain, right? It's kind of nutty, but your personal story is why ultimately every policy person is here. It's why these patient advocacy organizations exist, and it's why we're taking this fight. So your legislators care about you as constituents. They have to. That's why you elected them, right? Or somebody did. Make sure that they hear your story. Make sure they hear the cost to your family. Make sure they hear the cost to you. And don't be afraid to let your emotions show. That moves people. That makes it tangible. And your story matters.
Well, thank you, Jen. And thank you, Kara. And thank you, Matt. I would just echo what was said. PDABs really are an experiment. They are trying to patch over something that the sponsors don't understand, and your voice is critical to helping them understand the impact to your life, the impact to your family, and the impact to your community. And so your voice is critical. I know that we covered a lot of information here, and I apologize because there is a very complex system underlying PDABs and the PDAB effort. And that is the system that provides and delivers our therapies, our medicines, and our hope. And, we need to be enlisted. We need to force our way to the table. We need to make our voice heard. And as Jen has articulately stated, we need to be heard. So be direct. Share with them. Don't be afraid. Share your journey, share your story, and help them understand how access to your rare therapy is critical to your life and your situation. And that's how we're going to break through some of the noise around PDAB. And so with that, we'll go ahead and we will close this session. Well, I'd like to thank all of you again. Kelsey is already working on our March session. We will have a number of, updates to provide you, I am sure, by the time we have our session at the end of March. Keep watching the WRAP website. It is evolving. We are starting to build out some of the specific capabilities, and there's information going up on the WRAP website as well. We will continue to provide links to CAN, to ALS and to IDF, links to their PDAB materials as well, and as well as to specific materials from Colorado, Virginia, and the other states. Many of you are already producing good information, and we will continue to connect and share that again with all of those who are interacting with us here today and advocates that we're working with on the state level. So again, thank you for your time. If you have any questions, please feel free to reach out to us, reach out to our esteemed panel, and we look forward to working with you. And with that, we'll close.